start out by going through some case examples. These are some of the formal resolution cases that I had mentioned earlier with the resolution agreement and a corrective action plan. The majority of these cases have both the resolution agreement and the plan. The corrective action plan tends to focus on corrective actions that the entity needs to take going forward from the point that the resolution agreement is signed. Oftentimes it will include a 1, 2, 3 year period during which the entity has to provide information to OCR indicating that they are taking these steps and they're taking actions to bring themselves into compliance with whatever the issues were that are addressed under the resolution agreement. And each resolution agreement that OCR has entered into has also had a resolution amount. Those resolution amounts are calculated in part based on the chart that we just saw earlier with the potential CMP amounts. So there's a difference between a resolution amount and a civil monetary penalty. These resolution amounts are part of the resolution agreement, which is a voluntary agreement. It's like a settlement agreement. And the entity generally does not admit any fault, does not admit to a violation. And so these resolution amounts tend to be considerably less than the potential civil monetary penalty that could have been recuperated. And that's a reflection of the entity being willing to settle the case and take actions to come into compliance, and OCR not having to bring the case to a more formal stage where they would have to impose civil monetary penalties. So that's the resolution agreement corrective action plan. We'll go through a few of those cases here. These are the most recent cases. As I had mentioned earlier, I think now total OCR has entered into 16 of them out of the 80,000 plus complaints and 80,000 plus breach reports that we've received. And 4 of the 16 were from 2003 to 2009. So 12 have happened after high tech, more recently. And it's a reflection of a change in how OCR is conducting their enforcement. That we've actually, and I don't give a lot of presentations, but I give enough to have heard from a number of entities that do have an extensive privacy security program, that are putting forth the effort, are trying to do things the right way, that they really don't mind seeing these cases because it gets the attention of their directors, it gets the attention of their board, it gets the attention of whoever is controlling the resources in their organization. And they can show them these and they say, look at the potential liability, look at the potential risk if we don't dedicate resources to privacy and security. And so I think OCR has also decided that now that we're out of the infancy stage, all these entities should know about HIPAA. They should at least have policies and procedures. They should at least have trained their staff. And they should at least thought about these potential issues, that we want to see the policies and procedures. We want to see the training. We want to see that you took action after the fact and that you were prepared for this. In a lot of these cases that get to this point of a resolution agreement and a corrective action plan, there are certain characteristics. One, it's an issue that's been ongoing. It's a violation that persisted for an extended period of time. 2, it involved a significant number of individuals, hundreds of thousands of individuals. Or it was, and these are rare cases, but it was a 1 or 2 instance in time violation, but it was extremely egregious. It was clear that it was a real problem, there was harm, and it should never have happened. So those are kind of the types of cases, and so I'll go through a few of them and identify some of the key lessons to take away from these in terms of what were the issues we saw. And we said these issues needed to be addressed in a more formal manner. So the Affinity Health Plan agreement actually was announced last week. Affinity Health Plan is a regional health plan in New York. And they actually, so they leased a photocopy machine. And at the end of their lease, when it was returned, before it was returned, they didn't wipe clear the hard drive of the photocopy machine. So the photocopy machine had stored all of the PHI that it had been used, or that had been used with the machine. Unfortunately for them, CBS News happened to purchase that photocopy machine and saw the PHI. CBS News notified Affinity of this. So Affinity notified us through a breach report. And it's the first time personally I have heard of this type of a device being involved in a breach. And I think the key lesson is when you're doing your risk analysis, you have to think of every place that PHI, the ePHI might be. Where is it stored? Where did it pass through that it might potentially reside, even if you wouldn't expect it to? So, and I think it gets to a point that I'll make later about the risk analysis and how important it is to make sure that it's complete, make sure that it's thorough of your entire business practice.
I have a question.
Sure.
Do you know if this photocopy machine, if it was a matter of people scanning and then scanning records, or if it's just a matter of photocopying records and the machine had saved it on the hard drive?
I believe the information was on the hard drive. The hard drive had not been wiped clean.
It stores every image, whether it's scanned or copy.
Right. That would be my. I think that's probably likely. So it's the image of the document. Yes.
Did Affinity know that? I mean, most people don't know that a health machine does that. Did Affinity know that? They must have.
I don't know.
Yeah.
I'm not sure. I
Don't
don't.
have a relatively new thing.
Right.
Health machines be able to do.
I don't think Affinity knew that it was on there.
And were they-
Whether
were
Affinity.
they at fault?
I'm sorry.
Were they at fault?
Well, so the fact that it was the PHI that their entity was responsible for, they're in possession of it, they're responsible for the privacy and security of that information. And when that machine was purchased by CBS News, and CBS News was able to access the information, to look at it on the hard drive, it's a disclosure. And it is. Certainly is. Sure.
Are those settlement resolution amounts, does that include the money that the entity has to pay to mitigate the damages, or is that cash that's just given to you guys and you use it with regular operation, or where that money is?
So the resolution amount it tends to be a percentage of the potential civil monetary penalty that could have been recovered based on the violations, based on the evidence of violation. It tends to be a small percentage, actually. So if you have 344,000 individuals, I'm not sure how many days this violation would have been calculated out to, but I am almost positive the potential CMP was probably well over 10 million.
But did somebody actually read the records?
See, that was my question.
So
Yeah.
presumably CBS News did.
They did read it.
That's how they knew it was there.
Well, I mean, you can see it, you can see a record and go, oh crap, they didn't do gauze, and then call Affinity and no harm, no.
Right, and so the potential harm, right, that resulted from this, because it was obtained by CBS News, is much smaller than if it's a laptop that's stolen and you don't know who stole it.
Right.
Someone that's stealing a laptop likely there's more of a chance that information is going to be used for nefarious purposes than if CBS News were to get it. But the fact of the matter is that there's still, there was the information. The data was still subject to the disclosure, the risk, and it was clear, I guess that's not up here, but it was clear during the investigation that Affinity had not taken into account the fact that photocopiers would have this information. So it wasn't part of their policy and procedure to wipe clear. And it wasn't part of their policy and procedure to, or it wasn't part of their risk analysis to say, this is, the photocopier is a potential risk source for PHI.
And I'm assuming it wasn't part of the lease agreement either?
Yeah, where's this business associate agreement? Where, I mean, why should they have been responsible too?
Well, I mean, so ultimately Affinity was using the machine.
Right.
And Affinity was responsible for protecting and maintaining the privacy and security of the information that was on the machine. And so, and they're the covered entity, and so they're responsible.
But I think she has a valid point in the lease agreement or contract have something to say, or shouldn't it have addressed clearing a hard drive?
From the company that provided the copier?
Right.
Where do you lose that liability, when you're doing business with the copying machine?
Under the new rule, it would apply.
So, right, so ultimately the focus for the potential for the breach, right, is who's responsible for maintaining the information.
Right.
Okay. In terms of whether there was a responsibility for the company that was providing the machine to Affinity to notify Affinity that this machine maintains a hard drive and will retain the PHI, I don't think that there's no requirement in HIPAA that would require, there's nothing in HIPAA that would require them to disclose that, I don't think. Whether or not it's a requirement as part of doing business, if it's something that would be in the contract otherwise, it's possible. But in terms of maintaining the privacy and security of the information, this was Affinity's information within their control. And so they're ultimately responsible of not allowing it to be impermissibly disclosed. But I think that's the perception, or that's the perspective that we would look at it from.
But after September 23rd, then since the photocopier company would be a business associate, then they would be held liable.
It's not necessarily going to be, the photocopy company will not necessarily be a business associate. Just by providing a machine to do photocopying does not necessarily entail the use of PHI. So business associates, part of the definition of business associate is that they're providing a service that involves PHI. So when the company provides the photocopier, just providing the photocopier to the entity, that's not involving PHI. The only reason PHI was involved is because Affinity used it to copy PHI. And so there wouldn't necessarily need to be, if Affinity then intended to give the photocopy machine back to the company that's leasing the machine with the PHI on it so that the leasing company can get rid of the PHI, then they would certainly be a business associate because they would be intending to give the PHI to the leasing company. And there would be PHI involved in that relationship.
But it would be safe, though, for anybody that's processing PHI that in the agreement with that company that provides the photocopier, they're going to wipe the hard drive before that machine moves on to somebody else.
Sure, that's absolutely something the CE could include in the contract or could require.
However, it would still be the entity's responsibility if they didn't do it. ultimately. You could possibly
Unless-
sue the business associate later, but ultimately, sure, it was something.
But if there's a provision in the contract between the covered entity and the business associate that says the business associate will wipe clean the hard drive, and they don't do it, they don't appropriately protect the privacy and security, the health and the PHI that they know they're getting as part of this relationship, after September 23rd, then if OCR finds that there was a breach after that PHI was delivered to the business associate, OCR could go directly to the business associate and say, sounds like there's a potential violation here of what you were required to do in your contract with the CE.
However, that needs to be part of our policy also, not just be in the contract with them.
Sure, right. If that's the plan, if that's what the covered entity, if that's how the covered entity plans to protect that information that's on the photocopier, yes. And that's part of what wasn't envisioned, I think, in the Affinity case, is that Affinity didn't plan for how the information that was on the photocopier was going to be protected and ultimately deleted or rendered indecipherable and unreadable. So yes, a little bit of an expensive lesson. WellPoint, also relatively recent in this July. This was a case where there was an online application database that WellPoint operated, and I believe they made a change to their firewall system, or they made a change to the application, and it didn't go as planned, or they didn't foresee all the potential risks, and so it ended up that over 600,000 individuals' information was accessible to the general public on the internet. And so the real takeaway from this is whenever you're changing something with a web-based application, with really any part of your electronic system of maintaining PHI, particularly those that are web-based, take care in making sure that all of the protections that are needed are there. Be diligent. You may have started out in a terrific spot. Everything was covered. But as we all know, business processes change, improvements come, and so inevitably the systems themselves change a little bit and your business changes a little bit. And so that's also another reason why this risk assessment is so important, in that it's ongoing. It's a dynamic process. Your business is always changing, the risks are changing, and so it has to be an ongoing process. Just like a lot of training that you might do, there are always updates. There are things that you have to do on an ongoing basis to stay on top of everything. Same sort of thing with privacy and security. The Shasta Regional Medical Center, this is an example of one of those one or two instance issues. It was a violation in one or two instances that was so clear that it was a problem that it raised the level of a resolution, a more formal resolution. So a Los Angeles Times article had I think it was an interview with the senior leaders of the medical center when they provided PHI in the interview. They also, after OCR started to investigate, they also sent an email to the entire workforce with patients' PHI. And the fact, I think that the key point here is that it was senior leadership that was doing this in a very public forum, and also within the entity. And so a good privacy and security program absolutely involves the top level people. They have to buy in to a certain extent that this is important. And they certainly have to know what it's about, because it applies to them as well. They're a workforce member of the covered entity. So you might hear talk of establishing a culture of compliance. I personally don't like using that because I don't know what it really means. It's just kind of, it's almost cliche at this point to use it. But what I think it really means is building awareness around privacy and security. An awareness to the point that your workforce understands that it's an important issue, and it's something that in those circumstances where they're confronted with a decision, that it will be part of their decision making. To at least have it in mind, be aware of the potential risk. So it certainly starts at the top. In a number of cases that I've personally been involved in, I've seen the benefit of this. In a couple really big cases, in fact, where I've seen a dramatic change over a year or two in folks that are at individual sites. This isn't a national corporation. Folks that are at individual sites across the country becoming so much more aware of what it is they need to look out for and be concerned about, because the directive from their executives has been, this needs to be part of every training, not the same information, but privacy and security needs to be incorporated in some way. And there needs to be a regular reminder, whether it's from the middle management folks that visit people on site. What are you doing this week with regard to privacy and security? Has anything come up? Do you have any questions that I can try and answer? It really does start at the top with the senior leadership. And so I think that's something that they wanted to point out in this case. Hospice of Northern Idaho. This was, as you can see, a relatively small resolution amount compared to the others. This is a small provider, and it emanated from a breach report involving less than 500 individuals. And so, certainly, there's an incredible spectrum of types of CEs that HIPAA applies to. And one important part of HIPAA and how it's constructed, it's meant to be somewhat scalable and flexible to the different entities. That's part of why it's not as prescriptive as I think a lot of people would like. It doesn't necessarily tell you specifically, this is how you do this, this is how you should do this, but it kind of gives guidelines, it gives processes that entities have to implement in terms of policies and procedures, in terms of training, and it relies on the entities to figure out those specific decisions themselves based upon their business and what is important and how do these general processes that are required under the rule really apply every day. And so smaller covered entity is going to face different issues, different challenges. But in this case, it was a similar challenge to any entity, a stolen laptop. Again, we come back to the mobile device and theft. And besides the stolen laptop, once we started to investigate, we realized that there really was nothing in terms of a program developed. Again, moving from infancy to a more established period. Not having policies and procedures, not training, it's really going to stick out to us now if we come and look. The rule has been in effect since 2003, and so there should at least be especially even in small entities, there should at least be baseline policies and procedures. There should be some documentation that some thought has been given to how privacy and security applies to the PHI and that practice. And if there's nothing there, that's going to be alarming to us, and even if it is a small entity. So the last particular case we'll talk about is Massachusetts Pioneer Institute, another laptop that was stolen. In this case, this is a relatively large entity. It's affiliated with the Harvard Hospital System. But there was really no incident response planning. what if something happens? How are we going to address it? How are we at least planning to address it? You're never going to be able to predict everything that might happen, and so you can't be real specific in projecting the future, if you will. But the security rule does require you to have incident response procedures. Generally, how are you going to, if you become aware of a stolen laptop that's not encrypted, or you become aware of some other breach, how are you going to address the situation? How are you going to do it in a timely manner? If OCR sees that, if we see documentation, we see policies and procedures that indicate that this entity has at least thought about what they need to do, and then if something happens, that they implement that they take some action to try and mitigate the harm, mitigate risk, that will reflect well on us. Because again, like I said before, OCR knows that breaches will occur. They can't be completely prevented. And so we really do look, if we investigate, we really do look for the policies and procedures. It shows that you thought about the situation beforehand. We look for what your plan is if something happens, and if you followed it. And if you can document all that, you're putting yourself in a much better position. And then also the last element, which I already talked about, is encryption. You could avoid a lot of these headaches and risks from OCR's perspective if you encrypt personal mobile devices, encrypt information. So now I'm going to talk about different parts of a compliance program. A lot of this is probably going to be familiar to you, and I just want to reiterate the importance of it and maybe provide some more specifics in terms of what under each of these requirements OCR likes to see. But as I said, given that, sure.
A quick question on the Massachusetts
Sure.
there. The resolution amount was 1.5 million. Would that have been paid directly by them, or would they have had an insurance company that would have carried, some sort of a insurance that would have covered the 1.5?
That's a good question. I don't know if there are insurance companies. I presume that I would think that there's certainly a market for that. But I personally don't know if there was a policy that paid it or if they paid it. But it does, I think someone asked earlier what happens with that money. It does come to OCR, and it is used within OCR for enforcement purposes. Anything more specific than that, I'm certainly not privy to. It's well above my position. But that is relatively recent. The money used to go into a general fund, but now it's specifically to OCR for HIPAA enforcement purposes. So I just want to stress the importance of these compliance programs now that we are in a phase of, I guess, there are more formal resolutions, and we're past the point, for the most part, where if an entity doesn't have anything, we're probably not going to pursue the voluntary compliance approach. We're going to be less inclined to do it because the rules have been around for a significant amount of time now, at least, 10 years. So I think OCR is kind of, moving in the direction that we need to see something from the entity that they've considered this. So the key points, and I'll go into these in more detail, of a robust compliance program, training, policies and procedures that are implemented as opposed to developed and then put on the shelf and never really looked at, never updated. Internal audits, basically that means a periodic review. Review whether your policies and procedures are still relevant to what your business is doing. And then an action plan to respond to incidents. I've talked about that. So the risk analysis, I've talked about this too. It's at the heart of the security rule. It is the process that should be done to identify all the potential risks to your EPHI. In every single security rule case that I've been associated with, and that most that I'm aware of, we will always ask for the risk analysis. It's at the heart of it all, and so it's something that has to be done. And as I think the photocopier case pointed out, it needs to try and be as thorough as possible. Try and identify every place where that EPHI might be and what the risk to that EPHI is based upon where it is or where it's going. And so here are 4 bullets of what generally a risk analysis will include. It's not solely these 4, but these are certainly important. Likelihood and impact of potential risks, implementing security measures in response to those risks, documenting what you're doing. That's your way of showing us, if OCR comes around, what you did about this, that you are working on this. That's what we rely on, the documentation. And then the ongoing nature of the risk analysis, maintaining continuous, reasonable, and appropriate protection.
I have a question.
Sure.
Oh, we forget. I was going to ask about the ongoing part. If you contract with an outside entity to do your risk analysis, do you recommend how often to have an outside entity look at your program?
So I think it depends. It depends on, I think we would certainly recommend anytime there's a change in your system or your business process that affects EPHI, you want to review it. You may not have to review the entire program or everything, all types of EPHI, but any change that is going to affect certain information.
So we could actually review it ourselves and not hire an external
Oh, sure.
third party.
Absolutely. Yeah, there's no requirement under the rule, and it's certainly not, it's not something that OCR is going to require, or I mean, you want it to be thorough, and you know, there's a certain expertise I think that can be helpful in doing it, but it's not something that I think covered entities should feel like they have to always hire someone to do.
But for an initial evaluation.
Sure, an initial evaluation I think it can be very valuable.
Yeah.
In part because you want to make sure you capture everything, every potential risk. And then once you have that initial evaluation, you have a much better sense on what type of universe you're dealing with. And then you can maybe pick and choose within the covered entity in certain areas. So regularly reviewing access to PHI for potential security incidents, the effectiveness of the security, and then reevaluating potential risks. That goes to any changes. Those risks can always change if there's a change. Okay, so I didn't know whether to put this up here because most of you probably know this, but based upon the importance of finding PHI when you're doing your risk analysis and when you're putting together your policies and procedures to make sure that they cover all potential risks to PHI, I did want to just briefly touch on the definition of PHI. What is PHI? So there are 2 elements to it, really, is what it comes down to. There's there's the health information element. So it's information that relates to the individual's past, present, future physical and mental health and condition, provision of health care, or payment for health care. And then there's the individually identifiable part. And it's not only information that identifies the individual, but it's information where there's a reasonable basis to believe it can be used to identify the individual. So it's a reasonableness test. And that's, so that it doesn't have to be a name. It could be an address with initials in some cases. If you think it's reasonable that if it's a small town and it's reasonable to say that someone with the initials RB that lives at this address, you can identify who that is, then that's probably going to be PHI. So that's going to satisfy the individually identifiable piece. So I just wanted to put that up there just kind of as a reminder as to what PHI actually is. It doesn't have to have a name. It can include social security number, obviously, date of birth, address, those different identifiers. Policies and procedures. These are the basis for the compliance program. This is where you document everything. And it's, as I said before, it's not just creating them, but it's implementing them. If OCR comes to look and investigate and you have pristine policies and procedures, but then when we start to interview people and they never heard of these policies and procedures, or they say, no, this is how we usually do it, and it's very different from the policy. And then we look at the policies and procedures and we see that they were created in 2003 when the privacy rule came into existence and have never been updated. That's, in a lot of ways, those policies and procedures aren't that helpful. They're not helpful to you as an organization, and they're certainly probably not serving the purposes they need to serve for privacy and security. So implementation is important. And part of implementing, which I'll get to next, is training people on them so they know what it is. But revising them so they comply with any legal changes, so any changes to the rules like I just mentioned, or changes to your business is most often what you're going to need to revise them for your own benefit. And that's a requirement in both privacy and security rules that we have these policies and procedures. Workforce training. So another thing that OCR understands is that entities can't control everything that their employees do. It's impossible. But what OCR looks for in terms of training is that you control what you can. You can try and control the message. You need to document when you provide information to your employees. And it's training beyond the initial training when they come on as an employee. It should be ongoing and continuous. And like I said, from my personal experience, what I've seen, the most effective training programs are more than once a year. They are keeping the awareness in the workforce that privacy and security should at least be considered when they're presented with different situations. And the best way to do that is to continually remind them. It doesn't have to be an in-service training every time. It could be sending an email. It could be part of a newsletter. It could be part of like a group huddle if you have teams in different divisions or different departments of your entity. It can be very localized. Another benefit that I've seen, another effective way to train is really trying to tailor the message to what's relevant to what the individual is doing. So you can have the general HIPAA training for someone once a year when they first start out. But then the continuous training can be really focused on situations that they encounter every day, or situations or particular rules that really affect their duties as part of the organization. Because if individuals continue to hear about all these different regulations and rules that they certainly view as getting in the way of letting them do their job, they're going to tune it out. They're going to ignore it. That happens with me in some of the training I take. I understand. And so really trying to focus on something that's relevant to the individual, at least in the cases that I've dealt with, has been more successful and more effective. And then it's important that you document when you provide this training. That's something that OCR will ask for. Again, when we come in for an investigation, that's primarily what we're relying on, is documentation that represents that you've taken certain actions. Incident response, which I've talked about a number of times already, but just to break it down a little more specifically, there are different elements to it. There's the mitigation element. What are you doing after you learn of an incident to mitigate the risk or the harm that was caused by the breach or by the impermissible disclosure or the impermissible use? There's the incident procedures requirement in the security rule. It's a little more specific. That includes mitigation, documenting what you're doing for the incidents and what you're doing to respond. And then employee sanctions is a part of incident response. It's also, I think, really, really important in that it creates accountability. There has to be some accountability for people to take privacy and security, and for that matter, a lot of other requirements of a job seriously. Particularly if it's something that they see as a nuisance or something that gets in the way of letting them do what they're hired to do. There needs to be some accountability. And there can be a whole range of sanctions. The privacy rule does not dictate what those sanctions are. A lot of entities have a progression. They'll start with a verbal warning, then they'll go to a written warning, then they'll go to a counseling session, then they'll go to a final written and counseling session, and it goes up to termination. Depending upon what the violation is or what the conduct is, you can jump within that range. But creating some accountability, at least in the larger cases that I've dealt with, has absolutely made a difference. And so I think that it's a small provision in the administrative requirements section of the privacy rule that I think can be easily overlooked, but I think that it serves an important purpose. Okay, so are there any questions on what makes a really good compliance program? And I know that to some extent that was pretty general, but it really is, if OCR is looking at it, it really comes down to those specific requirements in the rule. It comes down to documenting that you planned with policies and procedures, with training your staff, with how you're going to respond, and that you then follow through with it. So, any questions on the compliance program before I get into some of the examples of guidance materials and resources that are available to everybody? Yes?
I have a question, something you commented on earlier, and you know, we're fairly new with billing insurances, direct insurances. And we would need a covered entity, and the insurance company would need the business association, right?
Okay.
So, I mean, we're talking new, like this month we've been doing this. So the question that has come up is, if we have a contract with an insurance company that we're going to bill them, and they're going to, you know, pay us for services, can a client say, I don't want this turned into my insurance, I prefer to just pay it? They have a right to do that, or because we have a contract with that insurance, are we required to bill them for services? I mean, I understand if the patient decides they're going to pay,
Sure.
then they can't turn it in on their own.
Right. So I think there are a couple pieces to that question. The first, with regard to whether you have to disclose the claim or provide the claim to the insurer if the individual is paying on their own, with their own money, out of pocket. That goes to one of the changes that I talked about earlier with the new rules that take effect. The compliance date is September 23rd. As of that day, the individual, if they pay completely out of pocket, they can request of the covered entity that the covered entity not submit their information to the insurer, to the payer. And the covered entity has to agree to that. That's only if the individual pays completely out of pocket. And as I mentioned, if it's a bundled service, you have to pay for all the service. That may not be relevant, but so that's that situation. In terms of whether your contract with the insurer requires you to provide the information for a billable service of when someone pays for it other than the insurer? I don't know. I mean, that's going to depend what's in your contract.
In the contract.
It's going to depend what's in your contract. But what I can say is that if you still disclose it to the insurer, it's still going to be a potential violation for HIPAA. Okay, and so in terms of how OCR would view that is our authority is to enforce the federal regulation. And so we're going to say, even if you have a contract provision, even if the insurer requires you to provide the information, doing so is violating the federal regulation. And so we're not going to be concerned with that contract.
If we have a statement that the patient checks off, I do not want my insurance bill. I do not want, how is that?
So,
you know, I give permission to bill my insurance, or I do not give permission to bill my insurance.
That's what you have now.
They should have that option. I mean, I think they should, but I'm just saying.
Right. So if the individual, are you saying even in situations where the individual is not paying out of pocket?
No, they would be paying. That would be the only time you would do it, if they agree to pay.
If the individual agrees to pay, right?
Yeah, they agree to pay. There's no need for us to bill, and if they don't want to, I feel like that's kind of a violation of their
And I think
wishes of how they're, how they want their medical information handled.
I think that's at the heart of why that change was made. And I think from Congress's perspective, not that I will ever speak on Congress's behalf, but what I suspect is that they saw that the purpose of the disclosure to the insurer is to obtain payment. If payment's already been obtained, there's no reason that the individual could not, there's no good business reason why the individual should not be able to request that the information stay with the CE. Does that answer your question?
Can I expand on that? Meaning, is it based on the date of service or all their services? Meaning, they came in yesterday and got an ultrasound, they wanted that billed to the insurance. Today they came in for a pregnancy test, they don't want that billed to the insurance.
So, right, so it's the individual treatment. It's the reimbursable service. Okay, it's by reimbursable service. I think your question raises an interesting point, which has come up in other presentations, and I don't have a good answer for it, is that what happens when an individual pays for treatment themselves, requests that the information not be disclosed, but then later on they receive other treatment that is going to be billed. But the insurance company needs to know information about the procedure that was done when they paid out of pocket. Then can the CE provide the information to the insurer? Even though it can ultimately present a safety issue, depending on what the service is. I don't have a good answer for that. And I think that's separate from the bundled service situation.
But would it cover us if we, at that point, we got the client to sign a release of information to release so far back?
Right, you have an authorization.
Would that cover it?
I don't have a good answer to that. I think that's something maybe I suspect, I mean, we've raised it with our policy folks that this is a potential issue. And I think I don't have the exact language off the top of my head so in the final rule, the 171-page final rule that I mentioned, there's a lot of explanation. We call it the preamble. There's a lot of explanation as to how to implement these different rules. And so they a lot of times get into different hypothetical situations. And I suspect that if that wasn't addressed in there, then it will have to be, because it's come up a lot, and I don't give that many presentations, but it's come up a few times. So I don't have a good answer for you on how that would work. Yes.
I don't know.
The question is kind of the end of the question that she asked. The client that has insurance, wants to pay privately, gets a receipt from us for the service, and then turns it into their insurance for reimbursement. That's kind of the end of it. We have a contract with those insurance companies, and they're coming back and saying, hey, we have a contract, or you're supposed to be billing us first.
Well,
So,
the understanding has to be, when they pay, that you're not gonna turn this into your insurance. Right? I mean, you have to make
So-
that clear to them, because we are the only ones who can send that bill to the insurance, because we're contracted with
Well,
them.
they could turn it into their insurance.
The individual,
They
I
won't,
think,
they
could.
won't pay.
Why not?
they won't pay them, they
They
won't pay
won't, they won't
us.
reimburse the patient. We found that out. They want us to refund their money, and then
It
bill
just
the
creates a
insurance.
mess.
It did create a
And
mess.
I think, just remember, the only situation where the covered entity is going to be prevented from providing the information to the insurer is when the patient specifically requests that it not be done.
And you need to have something right.
Right. It needs to be
Every
right.
time, not just the
Right,
time.
For each
visit,
service,
they would say whether or not they want their insurance bill. But if you give them that receipt, it's got the codes and everything on it, you have to say, now, you chose not to have us send this, so you can't send it. Because it's gonna create a problem for us if you do.
They have to sign off on it, though, that's the point.
Sign off.
Sign off.
You have to have a paper saying that they would explain that this cannot be billed to their insurance, that they made insurance. No, bill, not that bill.
Sign the state, because I don't have a bill.
Right.
Other state.
Yeah, it has to be specific, just like Medicare, it's specific. It has to be specific.
I don't know that you necessarily have to answer to this, but just something to think about if it doesn't come up already. Now with this new doctor's office where now that the physician practices are being required under Obamacare, ACA to give information about patients' care, like their blood pressure, their lab results. Quality measure. So is this rule about specific to the bill only, because we were wondering if those quality measure data, if a carrier, if we give information to, say, Humana, whatever, for their patients, and if one of those patients happens to be this person that said they didn't want their bill to go, is that going to be a conflict? And I don't know that you know the answer, but you see where we're wondering, with this rule, we've been thinking about the fact, is that going to be a conflict? That giving the
Right.
quality measure info
Right.
for the purposes of Obamacare, if a person happens to be one of those people that said, we don't have to send a claim,
Right.
but what about the
What
quality?
what kind of information is required?
They're looking for blood pressure, they want to like their blood pressure, their BMI.
Or PQRI,
Yep.
you're talking about?
Yeah.
Well, there's quality,
HIV
there's incentives too. Humana has a program.
Yeah.
Yeah, but it's my understanding, they only ask for the information on an individual individual client they if you bill. have submitted
Right.
a claim.
It's coming where they're gonna ask for all of
That's not true.
Oh, we've already been contacted.
data mining.
Yeah, they want a direct,
They want
a direct direct feed
So-
into the system.
So individual insurers will be requesting information about your entire patient
No,
base.
just their patient.
Just their,
They're insured.
They're insured.
their insureds regardless of
Claims or not.
claims.
They
Oh,
love
yeah,
to
because they're
get
not
on the
looking at
claim.
just the dates of service, they're looking at the medical record.
Right.
And the purpose is because under Obamacare, the focus is that a PC, two things, the quality that I think they want to go to a place where providers are paid based on outcomes. That's one kind of focus. And these are the precursors to all that. And the other thing is that a physician manages a patient's life, make sure they get all their preventive. I mean, they're going so far as asking for information about the person got their eyes checked and it's a PCP, a primary care. So in other words, that doctor is going to be responsible for the health of that patient.
Yeah, I don't have a,
I mean, it's nothing for you to answer, but it's
Right.
just something that that's in your head.
Yeah.
Challenge for
Laundry
us.
is, know healthcare entities are in.
Yeah.
That's where I go back to the question, it's all services, or that none of their services ever get billed to their insurance as a whole, or specific service. Because like, in community mental health, we may not bill their insurance at all, but since their client lives in our county, we are required to provide all of that information to the state about that client. So, and in the past, we've already told the clients, if you don't want to comply with this, then we can't see you in our agency. We don't even start the process.
Okay, now that's the first that I've heard of that specific situation. So it's good to know though. Yeah. Yes?
I have a question totally related to billing.
Yes.
With social media, phone, videos, pictures, if they take video, picture, whatever, I work in the ER, is that then considered electronic since it's being transmitted, but on Facebook and everything else?
Who's they?
Patients within, like if I take a picture of my son getting stitches and in the background is a picture of somebody, but is it the hospital's then responsibility since they didn't limit the patient taking pictures or taking information while it's there?
No, because it's that PHI isn't in control of the covered entity. It's a patient. It's a patient taking a picture. You could certainly, I think it makes sense for covered entities to prevent established policies and procedures that you certainly don't want patients wandering around the facility and taking different pictures of different people, right? But say the patient is there with their son, and generally the son is a minor, the patient is there with, or the individual is there with the son, the individual is involved in that son's care. They might be a personal representative if they're a parent or a legal guardian. That information about the son, it's the picture, right? That's the son's PHI.
But what if they're taking it in the waiting room or they overhear and they're tweeting and they're texting information of other people that they gained while they were hanging out? Because it's a hangout.
So there's really, yeah, there's no, I don't think the CE can control that, what the patient is doing. The CE can control whether that information is easily accessible to the patient. That's part of the safeguards concern, right? So not yelling out names in a waiting room, using just a first name, or having some other number system to call someone. Those are like real basic safeguards and examples. But in terms of if a patient is in a waiting room and they find out that they hear the person next to them talking about what they have, what their diagnosis is, or what they're there for, and then that patient then texts their friend and says, "Oh, so and so has this condition," that's not on the CE. It's coming from the patient, right? And it's not involving a covered entity workforce member impermissive or not exercising proper safeguards. It's not a matter of there's something on the wall that's posted that says this person is in this room for this issue, that kind of a thing where everybody can see it. So it's different. Do you understand the distinction?
Right. We just have been in a situation before where they are wandering or taking pictures or doing something like that, and we've said that that's a violation of HIPAA because you may see somebody who's here that doesn't want to be seen, but I didn't know if we could back that up or whether it was just kind of an empty threat.
Surprisingly, and I deal with all kinds of little weird situations like that, I haven't heard of that one. But I think that...
I work in an ER, everything is...
Oh, I'm sure you've seen everything. But I would say that it's in a covered entity's best interest to not... I mean, if you see that, that is a potential risk. right? It's a potential risk to have one of your patients or one of your visitors wandering around your facility.
You don't encourage that.
Obviously not, but I'm saying it's something that, right, you don't want to encourage it. In some ways you may want to discourage it, but if you have kind of a baseline policy that indicates if you just see someone wandering around and taking pictures and a nurse sees that person, the nurse should go up to the person and ask, what are you taking pictures of? What are you doing in this hallway? You know, that sort of a thing. Because ultimately it could lead to other risks.
Sure.
I mean, yeah. Yes?
What if it's a different scenario? What if it's the patient taking pictures of the staff members and posting things on Facebook? We've had that happen.
So.
And it's not nice stuff.
I'm sure it's not. I'm sure it's not. If it's going on Facebook, it probably isn't. So that actually is not going to be considered PHI.
Because they disclosed it.
Well, because,
It's not a violation of the staff member? I mean,
well, if the staff is working, the individual's working, and you go back to the definition, if you're thinking about, is that picture of a nurse working at a nurse station related to the past, present, or future provision of health care to that individual, payment of health care for that individual, or it's not really related to that individual's health care. It's that individual working. Now that's something that that could be part of an employment policy, or just a general policy for the facility that they don't want patients taking pictures. It wouldn't necessarily fall under HIPAA though, I guess is my point. I can certainly see the potential benefit of having that kind of policy. Now, if this case I've seen a number of times, unfortunately, EMTs taking pictures of people in an ambulance or people they brought in. And they're not necessarily, they won't necessarily include the individual's name, but then they post it. You can see their face. I mean, and so that gets into PHI. And so the social media and the picture taking with the phones and all of that is absolutely ushering in all these new issues for us to deal with. And that's part of the reason, what I'm going to get to here in a minute, is some of the, I mean, we really focus on workforce members using their phones and using social media and what guidelines need to be in place. What a covered entity has to do with regard to limiting how a workforce member uses social media in relation to their job. But in terms of patients, it's probably not going to be considered PHI.
what about texting? Nurse to physician, physician to nurse, doctor's orders?
Okay, so what about it?
On personal phone, the physician
Right.
just text orders to the nurse and the nurse texts back. They do it all the time.
Right, so that's
But we've had discussions about it, but,
right. So that's a use of PHI for treatment purposes.
well,
It's
my
permissible use.
is saying that we can't prove it because, I mean, we can't really look at their phones. We know they're doing it, but we have no proof that they're actually doing it. You know?
So this starts to get into the area of control what you can control. You should have a policy that clearly states if you don't want them to use personal phones for treatment purposes to discuss PHI, clearly state that. And if they say, well, I need to use a phone, well, then either give them a phone that's encrypted or set out very clearly what has to be on their phone that has privacy and security protection, where they can use their phone. Maybe it's a particular, and again, I don't know for sure if it exists, but maybe there's an app that has a certain level of security that encrypts the information. I know that there is encrypted texting. I know that that exists. Whether you can put an application or you can put that technology onto a personal phone to be used, I'm not sure. Or if you just need to get a phone, a specific phone that has the text.
We've had company phones and they did away with them for budget.
Okay, sure. All right, and that's certainly a challenge, and that's a consideration. But generally, that's a case if there is PHI being used and exchanged on personal devices, there has to be a policy. And if you find out about it and the policy is that they can't do it, there should be a sanction. There should be retraining. A sanction could be retraining. But if it keeps happening, then there should be, you know, the next level to show that it's not going to be accepted. It's not going to be accepted. Yeah.
My department falls into a little bit different category. We're disease investigators for local health.
Okay.
So PHI is permissible under Ohio Revised Code.
Okay.
3701. However, sometimes we hold PHI from like physicians' offices and things like that to do our investigation. If we are requested to submit records for like lawsuits or whatever, the records that we pull from a physician's office just for investigation purposes, are those ours to release, or would that person requesting have to go to the physician's office?
So an individual is requesting records for
a lawyer
for legal proceedings.
Yes.
Is it typically a subpoena from the court, or is it just a simple request?
A simple request. Yeah.
If you're, I'm trying to think. So you investigate. I'm wondering if you're a CE.
Excuse me?
I'm wondering if you're a covered entity. You're a business associate. I mean, I have to get a sense on what it is the business is, but if you're not a covered entity, then you don't have to worry about it.
Right.
It doesn't apply to you. If you are a covered entity and you have this PHI, then you have to maintain it. And if an individual requests a copy of their own,
this would be the lawyer on behalf of the individual.
right, so a personal representative on behalf of an individual, then yes, you would have to provide it to them.
Even though it's not our records that we...
Right, and that's why I'm wondering if you're a covered entity.
But who provided it to you? Did they stamp it saying that you could not re-release it to someone else? Because it should be stamped. Anything that comes from an entity should stamp their records that they sent to the lawyer that this is not re-released to anyone else. They have to go get it.
When it's sent to the lawyer.
Or to another doctor. You're not allowed to re-release something. If your doctor sends something to me, I can't release it to another doctor. It should be stamped that I can't release it to someone.
That's exactly what we should. I never release anything.
Nothing that comes from somebody else. So you would be able to release it to somebody else. Okay. That's another state law. That's another law.
I would never release that.
Yeah.
Is that an Ohio law?
That's federal law.
That was original HIPAA.
Okay.
But with the release of PHI,
it's not your record. It's not yours. That's what I'm
It's not the new entity else.
It's the covered entity, right. And what you create, you can release.
What you don't create, you can't re-release.
Right.
Right. So I think I would need to know whether you're...
I got the answer.
Okay.
Yeah.
Right. Good.
Thank you.
OCR is, particularly after high tech, we've been trying to provide more information, more guidance to covered entities, business associates. And my understanding is more is coming, particularly guidance for implementing the new rules. And so here's a few examples. We have actually a continuing medical education and just continuing education training module at Medscape. I don't know if you're familiar with Medscape. Most of you probably are. You have to create a username, but then it's free. The username's free as well. But it's this particular training is geared specifically to physicians. So I think it's appropriate for the individual practitioner or the small group practice, or if you're in a large entity, just having your physicians telling them about it. And they can go on there and they can get CME credit. And it's talking about creating awareness. And again, that's really, I think, a lot of what it comes down to. If you're just aware of the tenets that are behind privacy and security, then situations where a decision will have to be made, more likely make the right one. These are just some examples of instructional video series surrounding or pertaining to mobile device programs. As I mentioned, mobile devices are, because we see them as they're going to continue to be used and they're a real risk. We're trying to put out a lot of information surrounding use and appropriate programs for using mobile devices. So there are a number of videos at this healthit.gov website. There's actually a whole toolkit surrounding mobile devices, and there's another web address coming up for that. But these are educational videos. This WEDI Omnibus webinar series, there were 4 webinars that OCR participated in with WEDI to really get into some of the details of the new rules that I went through in that middle section of the presentation. There's a lot of good, I think there are a number of handouts associated with each webinar. You can watch the webinar. I think they're an hour and a half long. That's free, so you can access the WEDI website and view those. You may have to register with them also, but it's all free. The OCR also has a YouTube channel. Most of the videos on there are about a year old, and so they don't deal specifically with the changes to the rules. But that said, there's still they can still be particularly useful. They're fairly general, but it's another resource we have. Here's the web address for the mobile device toolkit. It's at the healthit.gov website. There are fact sheets, posters, brochures, videos, all kinds of information geared specifically for covered entities and BAs to help them think about the different issues that arise with the use of mobile devices and how to formulate privacy and security. And again, we'll be having copies of these. They'll be available with Ray. Here's an example of some of the tips, I guess, or one of the brochures, the posters that's on that healthit.gov website, just identifying, I guess, issues to think about and to address for mobile devices. And then our website. Our website actually has a lot of information if you can find it. It's not the easiest to navigate and it's not always very well organized, but there's a lot of good guidance materials. There are a lot of frequently asked questions that can be useful. All of the resolution agreements and corrective action plans we've entered into are on there, along with the actual resolution agreement and corrective action plan, a press release that kind of highlights the issues, and in some cases there's also some other guidance related to the issues that were addressed in the case, listed with the case. There are sections on training materials for covered entities and business associates. Some of it's pretty basic. I think there might be some higher level materials on there, but resources for covered entities to at least look at and maybe not take wholesale, well you could take wholesale to provide the staff, but at least use as a base to try and tailor to your needs. And then final rule substantive information, that guidance that's being developed, that will ultimately be posted on the website. Delivered receipt, and then you can prove that it was delivered to the correct address.
If they receive it.
But so, for example, an appointment reminder. A lot of doctor's offices send appointment reminders with postcards. And that generally is okay if it's limited to a reminder that you have an appointment on this date. And it doesn't have specific why you're going to the appointment, that kind of a thing. But if there's a situation where an individual requests specifically to have their appointment reminder put in an envelope, then that's something that the CE should do because it's an appropriate safeguard. It's a balance. It's this ongoing balance between enabling communication with patients. So patients, in our approach, patients at the top of the pyramid, doing what's best for the patient. But we also obviously have to respect the business processes of the covered entity, and you don't want to make things so completely onerous that you can't operate. And so there's that balance that has to be struck. And so postcards for appointment reminders are okay, as long as it doesn't include too much information. That's an example. Emails, I'm surprised that didn't come up.
I was just going to ask.
Emails and faxes, those are the
So faxing is like regular mail. Faxing, you want to verify you have the right fax number. It's also good to know where that fax machine, where it's coming out. Is it coming out in a public space? Like at most doctor's offices, the fax machine shouldn't be next to or on top of like the counter where it's just out for people in the waiting room to see. So that's a consideration. But for emails, it's becoming more and more popular. A lot of patients want it. They want to communicate with their doctor via email. And that's fine. It doesn't have to be encrypted. It's great if it is. But if it's not, then the entity should get a consent from the individual. And the consent should indicate, we're happy to communicate with you via email about your treatment, but be aware there is a potential for, there's a risk of disclosure when communicating by unencrypted email. So you're notifying them of a potential risk, and they're consenting to communicating with you and receiving their information in that way. Then you're good.
And it shouldn't be longer than 6 months, just so you know that. You need to make sure that you're making that client aware every 6 months that they're giving you consent.
Yeah.
They have to be, you can't say that they gave you consent 2 years ago and you sent it.
It's each event, actually, or
No,
each
no,
visit, or?
No, it doesn't have to
It
be
doesn't
each
have to be.
communication.
No,
Oh,
regardless, but it needs to be the
Time
you
period.
read to make sure that they're
Agreed upon time.
Yeah.
So that's another example of the balance. Obviously, people are going to be using email, and patients want email. And in some ways, it's good for the entity, too, to be able to conduct care that way, or treatment. But there's a risk involved with that.
And your biggest risk is that you're not reevaluating that release.
Right, potentially. I mean, if we were to come in and we see that you're communicating via email, although if the patient wants you to communicate via email, we probably won't hear about it. But if, say there's a breach, or say something happens to your email system where the security is compromised, and we come in and we see that you're using PHI via an unsecured email, and there's no consent with the patient, that would be an issue.
At the health department, we're subject to sunshine of emails, but that would not be if you're emailing a patient.
And medical information is different than the sunshine law.
Yeah, I think that's different. I don't know much about the
Because you now become an entity because you're getting profit off of it.
Yeah, I don't know enough about that law to comment really.
We have a company in town that we do vaccines for. And he used to send, these are the patients that need their hepatitis Bs. And now he says, oh, I'm not allowed to do that anymore. So we're like, oh.
In an email?
Faxing. You know, faxing, these are the people who need hepatitis B shots or TB test, whatever. And he says, I'm not allowed to send them anything anymore. I have to actually give it to them, and they have to hand deliver it to me, so there's no way I can know ahead of time.
If he gets a signature from them releasing that, that's different. He needs to just get a signed signature.
Unless there's something specific in Ohio that deals with immunization information, because that could be. So there are states, obviously there are state laws regarding privacy of health information, and some of them are more stringent than HIPAA. HIPAA is what's considered a floor.